morning. Today I am going to talk on statin intolerance. Uh, we know statin use has increased progressively in all age groups since 1988. The American Heart Association, American College of Cardiology guidelines have broadened the indications for the use of statins. Statins are among the most prescribed drugs in the world and are the first line therapy in the management of hyperlipidemia. Their beneficial effects in cardiovascular morbidity and mortality is very well established both in primary and secondary prevention. They are generally safe, but some patient statin therapy is stopped because of intolerance to the drug that may result in muscle aches, weakness, GI side effects, liver enzyme abnormalities, and other non-specific discomfort, and sometimes very severe rare complication. The rate of reported statin related events in about 5 to 10% in randomized placebo controlled clinical trials. If you see, there is a 21% decrease in CVD mortality and morbidity, that is stroke and fatal coronary events, can be achieved by lowering LDL-C level by 1 millimole, that is around 38 milligram per 100 ml. So, various indications to use statins are dyslipidemia, coronary artery disease, acute coronary syndromes, diabetes mellitus, stroke, hypertension, CKD. These are the very well established indications to use statins. So, coming to the definition of statin intolerance, according to the International Lipid Expert Panel, the inability to tolerate at least two statins, one statin at the lowest starting daily dose and another statin at any daily dose. So, and the resolution or improvement of symptoms or changes in biomarkers with dose decrease or discontinuation of the drug. Symptom or changes in biomarkers are not attributable to established predisposing, that is, it is not because of some other predisposing factors such as drug interactions and recognized conditions increasing the risk of statin intolerance. If you see the pharmacology of statin metabolism, it is it acts on the HMG-CoA reductase inhibitor step in the cholesterol metabolism, which is the rate limiting step. So, there the National Lipid Association scientific statement on statin intolerance in 2022. According to that, one or more adverse effects associated with statin therapy which was resolved or improves with dose reduction or discontinuation of the therapy. There may be complete or partial statin intolerance, complete inability to tolerate any dose of the statin, partial inability to tolerate the dose necessary to achieve the patient specific therapeutic objectives, but statin still can be used, but not at the low doses. For diagnosing statin intolerance, a minimum 2 statins should be attempted, including at least one at the lowest approved daily doses. So, coming to the statins mechanism, if you see, the statins act on the HMG-CoA reductase inhibitor step, that is, and through this there are various products which are affected by the statins. The cholesterol metabolism, which is the main reason to use. The cholesterol is responsible for membrane stability, then the stored steroid, it is required for the steroid hormone, vitamin D station, then the pre-annihilated proteins which are required for the regulation of GTPases, membrane stability, and other factors, the protection, protein structure and function. Then the dolichols, which are the protein electrophilation, then the cell growth, and then the ubiquinone, which is required for the mitochondrial density. So, by statin is theoretically acts on because on these all factors when it is and which can cause the side effects. So, the drugs which are inhibitors of the various cytochrome enzymes, because the statin is metabolized mainly by the liver, but of course, some statins are by other mechanisms also. So, by it can affect the various functions like the factors which are predisposing to the statin intolerance are the demographics, advanced age, female sex, low body mass index, comorbidities, that is patient with chronic renal disease, chronic liver disease, drugs which increases the high statin dose, then the inhibitors of the enzymes, CCP, various enzyme inhibitors, then the genetic factors. So, statin myopathy can be divided into depending upon from myalgia to myopathy to rhabdomyolysis. So, various predisposing factors which I already discussed: older age, that is age more than 80, female sex, low body mass index, Asian population, pre-existing neuromuscular disease, family history of myopathy, several renal diseases, impaired hepatic disease, hypothyroidism, diabetes, genetic polymorphism. And the modifiable endogenous factors: high statin dose, excess alcohol or grapes use, illicit drug use, heavy exercise, vitamin D deficiency, potential drug to drug interaction, gem fibrobil use along with the statin, then amiodarone, calcium channel blockers, colchicine, antipsychotics, etc. If TSH level, this is the thyroid stimulating hormone level, is more than 10 and thyroid is and TSH 4 to 10 requires thyroxine substitution for at least 3 months. Even if after thyroid TSH normalization, if there is a residual dyslipidemia, statin should be initiated. Alcohol consumption should be limited to prevent the side effect statin intolerance. Now coming to the muscle symptoms, various observational data shows that about 10 to 20% of the patient treated with statin complain of muscle symptoms, usually muscle aches. Analysis of muscle symptoms in double-blind placebo-controlled randomized trials of statins have shown a small numerical increase in muscle symptoms by about 0.3% only, which is not statistically significant. So, PRIMO study, observational study in around 8,000 patients, various muscle symptoms with the various this thing you see maximum with the simvastatin, then atorvastatin, and then other statins. So, statin related muscle symptoms prevalence, that is SAMS prevalence, in research clinical trials it is less than 5%, in clinical practice it is 10 to 15%, and according to the National Lipid Association it is 5 to 30%. So, statin associated muscle symptoms clinical index can be divided based on various factors, that is the regional distribution, that is location and pattern of muscle symptom, then the temporal pattern, that is symptoms onset less than 4 weeks, symptoms onset more 4 to 12 weeks, and symptoms onset after 12 weeks. Then the D challenge, that is the improves upon withdrawal within 2 weeks, improves upon withdrawal after 2 to 4 weeks, does not improve even after withdrawal after 4 weeks. And the re-challenge, same symptoms reoccur upon re-challenge, that is less than 4 weeks. So, various these factors, various points has been given the numbers, and if you see the if the probability of the statin myalgia is if the score is is 9 to 1, possible if it is 7 to 8, and unlikely if it is less than 7. So, depending upon the score given to the various factors like regional distribution, temporal pattern, D challenge, it can be, we can judge whether it is statin induced myalgia or it is unlikely to statin. Coming to the statin associated muscle symptoms assessment guidelines, if you see on the SAMS is less likely depending on the nature of the symptoms, if it is unilateral non-specific distribution, but if it is bilateral, large muscle groups are involved, then likely to be statin induced. Then that symptoms, if the symptoms are tingling, twitching, they are less likely to be a statin induced. But and then the timing of the symptoms, onset before statin, of course it is not because of the statin, then onset more than 12 weeks after statin initiation, again it is the less likely because of the statins. Onset 4 to 6 weeks after statin in starting or after statin doses increase. Then the other consideration, non-statin causes of muscle symptoms including conditions of hypothyroidism and vitamin D deficiency and use of other heavy or heavy physical activity, immunosuppressive or active agent, all this should be then it is not likely to be because of the statin. Risk factors with the SAMS include like the medicine or food interactions, high dose use of the statin, heavy or excess heavy myopathy, regular vigorous physical activity, these all can it is most likely because of the statin. So, then the classification of the statin related muscle toxicity, it is from grade 1 to grade 6 depending upon the CK levels, symptoms. If it is CK levels is less than normal, if it is CK level elevation is less than 4 of the upper limit, if it is more than 4 but less than 10 of the upper limit, and if it is more than 10 of the upper limit of the normal, depending, and then the last one is the autoimmune mediated necrotizing myositis. So, if it is SRMO 0 does not preclude statin therapy, consider reducing the starting dose. If it is class 1 to 3, manage according to the pathway that I will discuss later. SRM 4 is to discontinue statin therapy and consider alternative lipid lowering therapy. SRM 5, that is the rhabdomyolysis, immediately stop statins, urgently refer to the patient to the assessment and management. And statin induced necrotizing autoimmune myositis should be suspected in patient with progressive muscle weakness and ongoing CK elevation despite statin withdrawal. It requires immunosuppressive treatment and avoidance of re-exposure to statin. Reassess the need for lipid lowering therapy, may be eligible for treatment with PCSK9 inhibitor. So, you see the statins are lipophilic or hydrophilic. So, lipophilic statins are metabolized to the cytochrome 453A4 and produce more statin intolerance. So, lipophilic statins are lovastatin, simvastatin, and then the atorvastatin. But all statins undergo hepatic metabolism, but the pravastatin and rosuvastatin has the additional renal metabolism as well as. The PRIMO study, the use of the depending on the high intensity, moderate intensity and low intensity. High intensity reduces the cholesterol level by more, LDL-C level by more than 50%. Moderate intensity reduces the LDL level by 30 to 50%, and by low intensity it reduces the LDL level by less than 30%. So, various risk factors, as I already discussed, for statin associated muscle symptoms are advanced age, female sex, physical disability, low body mass index, hypothyroidism, associated use of colchicine or alcohol, and heavy exercise. So, risk factor for statin associated muscle symptoms: medication metabolized by the cytochrome 3A4, which inhibits this enzyme and increases the statin levels, like azoles, macrolides, protease inhibitors, calcium channel blocker, tricyclic antidepressant, cyclosporin, amiodarone, etc. And the use of grapefruit inhibit, which inhibit the cytochrome P3A4 at the intestinal level. And of course, the gemfibrozil, which is sometimes used along with the statin, interfere with the statin glucuronidation. According to if you see the New England Journal of Medicine publication, the chances of getting fatal rhabdomyolysis. So, if you see, there are lakhs of patients who has been tried, and the rate of rhabdomyolysis with various statins is varying from 0.919 to 0.04 and maximum up to 0.15. So, it is very less chances of getting rhabdomyolysis. In here you see hundreds of thousands of patients have been studied. So, approach to the symptomatic statin related muscle problems is take the history, do the physical examination to determine potential causes, check CK levels and review other labs, that is the creatinine, TSH, vitamin D level. If the CK is normal, then it is myalgia. If it is CK is less than 10 of upper limit, then it is myopathy. But if the CK level is more than 10 of upper limit, and you should rule out rhabdomyolysis. It is alarming serious condition. Immediately check for the creatinine, urine myoglobin. Then step 2, if the normal CK, it is just myalgia, lower statin dose or discontinuous depending upon severity of symptoms. If severe CK is less than 10, again you can lower the dose of the statin. Moderate to severe symptoms persist, then weekly contact. If symptoms resolve, re-challenge with the statin. If symptoms persist, appropriate referral is required. If CK level is more than 10, as already discussed, it means that there is a possibility of rhabdomyolysis, discontinuous statin. It requires intensive management. Severe muscle injury, re-challenge is not appropriate in these patients. If statin re-challenge, use different statin or alternative doses. Rosuvastatin 5 mg, atorvastatin 10 mg twice a week, etc. or pravastatin. Reassess patient within 6 weeks. Clarify patient's LDL goal based on ASCVD risk. Step 3, reassess patient within 6 weeks. Clarify patient LDL goal based on ASCVD risk. In not tolerate low dose statin, then switch to the other non-statin agents. And if the tolerate statin not reaching LDL goal, then you add the other non-statin agent. Tolerate statin reaching LDL goal, then continue drug and follow. If the CK elevation is more than 10, rule out again rhabdomyolysis. Coming to the coenzyme Q10 may reduce statin-induced muscle symptoms. No large well controlled studies has been shown. It has minimal side effects. Then the interaction between statin and exercise, the combined use of statins and exercise training can result in health gains and decrease CVD risk, but the use of heavy exercise sometimes causes the more statin toxicity. So some of the events, decreased athletic performance may occur, muscle injury, myalgia, joint problems, etc. can occur with the statin use. Various strategies to decrease the risk of adverse interactions between statin and exercise training are: reassess the need of statin, decrease the dose of statin, change the hydrophilic statin to lipophilic statin, change to a hydrophilic statin, prescribe a statin holiday followed by re-challenge, decrease the intensity of exercise training, decrease the duration of exercise training, prescribe vitamin D replacement, prescribe coenzyme Q10, etc. Avoid drugs interaction that increase toxicity. Then coming to the statin hepatotoxicity, statin related elevation in aminotransferase is up to 2% of the patient. Asymptomatic rise in aminotransferase activity more than 3 times of the upper limit normal is common side effect that normally resolves with dose reduction and is not associated with histopathological changes in the liver and in the absence of increased bilirubin. When aminotransferase elevation is associated with increased bilirubin, statin discontinuation and monitoring of liver dysfunction is necessary. Other side effects include hepatitis, cholestasis, acute liver failure. A patient with chronic liver disease including non-alcoholic fatty liver disease, chronic hepatitis, primary biliary cirrhosis, follow-up liver function tests should be done. Although these patients are not higher risk for hepatotoxicity than the patient with normal liver function. Statin therapy to be safe in non-alcoholic fatty liver disease. This reduces the risk of cirrhosis and hepatocellular carcinoma. Statin and liver, again the reversible dose dependent and asymptomatic elevation of liver enzymes is common. Persistent elevation of liver enzymes more than 3 of upper limit of normal in about 3% of patients receiving higher doses of statins. Liver enzyme elevation alone without increase in bilirubin does not indicate severe hepatic injury. Hepatotoxicity, atorvastatin most implicated for hepatotoxicity, simvastatin, fluvastatin, prozvastatin is more than rosuvastatin. 3 prospective studies shows that symptomatic statin induced hepatotoxicity in -87% due to hepatocellular injury, cholestatic and mixed injury seen with atorvastatin. Drug induced autoimmune hepatitis seen with atorvastatin, similar clinical, biochemical and histological parameters, and non-drug induced autoimmune hepatitis. So, an assessment by the Statin Liver Safety Task Force 2014 update, NLS Statin Safety Task Force, there are some questions which to be answered. Question 1, have any unexpected safety concerns arisen since the regulatory recommendation that liver enzymes need not be measured after initiating statin therapy? No, it should be measured. Irreversible liver damage with statin is exceptionally rare and is idiosyncratic. Yes, it is very rare. Then, should baseline liver enzymes be obtained before initiating statin therapy? Yes, it should be done to monitor the side effects, and of course, it is good for medical legal purposes. Liver enzyme test should be performed before starting statin and clinically indicated thereafter. Are statins safe to use in patient with non-alcoholic fatty liver disease? Yes, that can be used. Chronic liver disease and compensated cirrhosis were not contraindication to use statin therapy. Can a statin safe in patient with autoimmune hepatitis? Yes, they can be used in these patients. So, causes of elevated liver enzymes apart from statin may be the celiac disease, congestive cardiomyopathy, some use of the alcohol, fatty liver, gallbladder disease, some infections, autoimmune, and some associated medications. Patient with elevated liver enzymes, if it is less than 3 times of the upper limit of the normal, take the history and physical examination for other causes, review prior liver enzyme test, because the liver enzyme test may be elevated before starting statin therapy. Repeat test to confirm elevation. Total bilirubin normal, CK, if the total bilirubin is normal, CK is normal, But if the total bilirubin is elevated and CK is normal, then there is, if total bilirubin is normal, CK is normal. If the most diagnosis is non-alcoholic fatty liver disease, okay to start statin lifestyle changes, repeat liver test after some time. If total bilirubin is elevated, but the CK is normal, if the prior bilirubin may be elevated before the starting the statin therapy, like in Gilbert syndrome, asymptomatic, prior bilirubin is periodically elevated, it is the indirect bilirubin which is elevated, then you can continue the statin therapy. Prior bilirubin is normal, now bilirubin is get elevated, especially if it is direct bilirubin, that is it requires attention. Stop statin, stop other drugs that may have liver toxicity. If patient is overweight or obese, lifestyle modification, check various blood tests, that is liver function test, and required special tests. If required, liver biopsy and imaging of the liver enzyme does not improve with discontinue statin and lifestyle change. Patient with enzyme levels more than 3 times of the upper limit of the normal, again do the history and physical examination, repeat test immediately. If the enzymes are more than 3 times of the upper limit normal but CK is normal, then stop statin, stop other drugs that may have liver toxicity. If the patient is overweight or obese, do the lifestyle modification, check albumin level, prothrombin time, and do some other diagnostic, and if required liver biopsy. Don't improve with discontinued statin and lifestyle change. So hepatotoxicity, FDA says that 1 million treatment of goes into the liver failure. Merck worldwide adverse event database, 1 per 1.14 million patient goes in the liver failure. So 0.1% of the 23,000 patients with severe transaminitis. Coming to the new onset type 2 diabetes mellitus, the incidence of new onset diabetes with statin in treatment appears to be more common with elevated, if there is a elevated body mass index, impaired fasting glucose level, elevated HbA1c, older patient, and high dose statin. So there are predisposing factors. But diabetes is more with the high potency statins than the low potency statin. So benefits of statin treatment exceeds the risk of diabetes. Treatment of 10,000 patients for 5 years with 40 mg atorvastatin daily would be yield 50 to 100 cases of new onset type 2 diabetes. This is far outweighed the beneficial effects of the statin. So still the statins should be used. Clinical indication studies, statin induced type 2 diabetes. Jupiter trial, patient with more than one risk factor for diabetes randomized to 20 mg daily rosuvastatin were at increased risk of developing diabetes despite the reduction in LDL-C levels and cardiovascular events and mortality. Then coming to the neurological side effects, this can be hemorrhagic stroke, cognitive decline, peripheral neuropathy, depression, confusion, memory loss. The mechanism behind is the direct action of the statin blood-brain barrier, selective permeability to substrate, and decreases cholesterol level, which causes negatively affects formation of neuronal cell membrane, myelin sheath, and nerve synapses. Lipophilic statins because the high risk because they crosses the blood-brain barrier. Then the hemorrhagic stroke, to lower the cholesterol in people with hypertension. A special trial shows that stroke prevention by aggressive reduction in cholesterol level. That's shown that the definitive reduction in ischemic stroke with 80 mg statin, but there is an increase of risk of hemorrhagic stroke. Statin induced psychiatric effects like aggression, agitation, irritability, mood changes, very rare but sometimes seen. Coming to the nocebo effect, is statin toxicity all in mind? The adverse symptoms that are not caused by active component of a treatment but rather caused by negative expectations or perceptions of the treatment. Explain benefit of statin to the patient, reinforce healthy diet and exercise. So the potential risks are modest. Risk of new onset diabetes, muscle symptoms, rare clinically relevant liver that is outweighed by reduction in LDL-C levels, regression of coronary atheroma, reduction in ASVD events. So the prospective meta-analysis of around 90,000 patients in 14 randomized trials shows benefits of statins are well established in all-cause mortality, coronary mortality, non-fatal stroke, and major vascular events. And benefits are known fact. It is more with the highest intensity statins are better than the low intensity. The effect of statin on CV events rates related to 1 millimoles LDL reduction, it is seen in all prospectives, whether and it is more with the higher doses as compared to the less statin doses. So there is absolute benefit of statin events prevented by reducing LDL 1 millimoles for 5 years. You see that in the secondary prevention, it causes reduction in major coronary events, coronary revascularization, stroke, major vascular events, and it's also in the primary prevention. So what is the National Research Association recommendation for the ASCVD management? If patient is demonstrating non-adherence or lack of persistence with statin therapy, therapy should be evaluated in a patient's contributing factor, and the statin intolerance should be considered. For patient with suspected statin intolerance, clinician should attempt multiple strategies to, like the decreasing the dose, alternative doses, etc., to continue the statin. When non-statin therapies are used, there with the form of randomized trials, therapy reduced cardiovascular event risk should be favored. And if still patient does not tolerate statin, then you can use other molecules. So this is the summary of the various uses of statin, when to continue, or what level CK level should be checked, what level enzyme level should be checked. So the treatment is, this is the study from the in patient with statin intolerance in Cleveland Clinic experience, which was done in the Cleveland Clinic. Here this rate has been reported as a high as 20% in observable studies, that is statin intolerance. The discrepancy between clinical trials and observational studies can be explained by patient selection in randomized trials, which often exclude old patients and those with many comorbidities and enroll few women. Some adverse effects of statin therapy, such as muscle pain and liver enzyme abnormalities, are thought to be dose related. It is recognized that 20 to 40% low density lipoprotein cholesterol reduction can be achieved with the lowest daily dose of statins approved. Furthermore, an additional of 6 to 7% can be achieved with each doubling of the dose. So switch to a different statin or re-challenge with the same statin using a lower dose. Patients who do not tolerate statin on daily basis, alternate day or twice weekly dosing is a good option. Rosuvastatin and atorvastatin have longer half-lives, permitting their use on a non-daily regime. Adding ezetimibe to a lower dose statin may be better tolerated with robust reduction in LDL-C. Once a new regime is tolerated, dose frequency can be uptitrated slowly. So start with the once weekly, then twice weekly, and then alternate date, like that. So practical options: de-challenge, re-challenge, stop the statin, and allow 2 weeks without washout period to see if the symptoms resolve. Restart some statin or at the same statin at lower dose, or use a different statin. Switching to a statin that is metabolized by different pathway may work. Then if the patient reluctant or failed daily statin, try intermittent dosing. Then every other dosing can be effective for in lowering LDL-C level. So in the Cleveland study, they reviewed around 1600 patients with statin intolerance, referred to a single institution, and assessed serum lipid level. The most important finding of this study is the most statin intolerant patient can tolerate some form of statin therapy, and that intermittent statin use can be an option for some patients to achieve improvement in serum lipid levels. The other interesting finding was the trend toward a survival benefits in patients who were able to tolerate some form of statin therapy compared with those who discontinued the statin therapy. The statins have well documented benefit, and their discontinuation has been associated with increased risk for CV events. So we should try to give the benefit of statin to as many patients as possible. The result of this and other studies suggests that for most patients who report statin related events, especially high risk patients, statin can safely be re-prescribed with a higher probability of long-term intolerance. Intermittent statin dosing is regarded as an interesting strategy in patients with statin related symptoms. A recent review of several small studies by Marcus et al. Suggests that alternate day dosing of statin therapy may achieve similar LDL-C reduction compared with daily dosing. Bex et al. Showed that the mean LDL-C decreased by around 35% in 51 patients on every other day rosuvastatin dosing. And then other studies like Gadrella et al. Showed a 27% LDL-C reduction with rosuvastatin 5 to 10 milligram twice a week in 40 statin intolerant patients. Rusinger etc. have shown that 23% LDL-C reduction using rosuvastatin 5 to 20 milligram once a week for 4 months. Then other statins including atorvastatin, simvastatin have also demonstrated effectiveness with intermittent dosing in small studies. So, conclusion, the study showed that the prior statin intolerance does not preclude long-term statin therapy and achievement of ATP3 goals. Most patients with statin intolerance are able to maintain a stable long-term statin treatment regime. A strategy of intermittent statin dosing can be an effective therapeutic option in some statin intolerant patients and may result in LDL-C and achievement of LDL-C goals. So, the non-statin alternatives are ezetimibe 10 milligram per day, lowers LDL by 15 to 20%. It is well tolerated, can be used with statin or without statin. Then the bile acid sequestrant, and then the ezetimibe plus bile acid sequestration in combination. Then of course the bempedoic acid 180 milligram daily can be used with ezetimibe, and if you can combine the plavastatin 4 milligram, ezetimibe, bile acid sequestrant. It is a good affordable triple combination. Then of course the PCSK9 inhibitor and other drugs. So, myalgia resolution with vitamin D. One 28 patient treated with myalgic patient, serum vitamin D level was low. Of these 38 were given vitamin D supplements while still on statin. Serum vitamin increased from 20 to 48, and there was a resolution of myalgia in around 92% of the patient. Then the bempedoic acid, if the first synthesis of cholesterol is inhibited at an earlier step than the HMG CoA reductase, and bempedoic acid is a product and is converted to active coenzyme A form, and it does not affect on the muscles. So, it is the muscle side effects are not there with the bempedoic acid, and it is shown to reduce the CV death and mortality, not up to the level of statin, but still in the statin intolerant patient, and can be used in combination with ezetimibe. Thank you.